All right, well, welcome back to Ultrasound Grand Rounds again this week. The weather's warming up here in Cleveland. Things are starting to get a little bit nicer. We're getting out of the winter season. It's just becoming a good, fun part of the year. And it's a good day to do some ultrasound. But before we get into today's topic, just some pretty exciting news on the Ultrasound Grand Rounds front. So we just tipped over 10,000 subscribers to the YouTube channel. We've been doing this for about 4 years now, almost 4 years coming up here in May. And it is pretty incredible to see the response that we've had as a result of the lectures that we've posted. And so for all of you guys who are in the audience, thank you so much for your support, for your comments, for watching our videos, for sharing them. This really wouldn't be possible without you guys. And so it just gives us more encouragement to keep, putting this content together, to keep bringing new stuff to you guys to help you promote your ultrasound education and ultimately patient care as you're caring for patients at the bedside. So with that being said, we're going to switch on over to today's topic. And Dr. Werner is coming in today. She's coming back to talk to us a little bit about ocular ultrasound. And we've talked about ocular ultrasound before, but as we've been going through some, back to the basics this year, we thought it'd be helpful to get back to some basic ocular ultrasound. So without further delay, I'm going to turn things over to Dr. Werner and take it away, Sandy. Thanks.
Hi, I'm Sandy Werner, and I'm the Fellowship Director at MetroHealth Medical Center for our Emergency Medicine Ultrasound Fellowship. And I'm going to talk to you today about ocular ultrasound. And I'm actually going to break this up into two parts. So we're going to have part one, which focuses mostly on the normal eye, so scanning techniques, biosafety, and the normal anatomy of the eye as seen by ultrasound. And then in part two, we'll go on and discuss a lot of different pathology. I tried to put it all together in one, and it was way too long. So we're going to talk about ocular ultrasound, using sound to see what's going on in the eyeball, which sounds a little weird, I know, but it's actually a really useful tool. And for those of you who do lots of ultrasound, we look at many parts of the body with ultrasound. So now we're going to actually take a look at the eye with ultrasound. So, of course, I have no disclosures. If anybody wants to fund me, I'd be happy to take it. But right now, I have none. So we are going to talk about the indications for ocular ultrasound, how to do it, some safety things, the normal ocular anatomy, and then the sonographic ocular anatomy normals. So why do we do ocular ultrasound? Well, a lot of times we can't really see what's going on with the eye. Sometimes with the ophthalmoscope, we can't see anything. Sometimes there's eye trauma, and then we can't see anything beyond the lids. So some cases that might bring us to want to use ocular ultrasound. You have someone with a high degree of myopia. They come in and they have loss of vision completely in one eye or just part of one eye. And, you can't really tell what's going on. And even if you have your fancy ophthalmoscope, it might actually be easier to look with ultrasound. You have a 64-year-old guy who comes in and he's suddenly got all of these floaters and he has a history of diabetes. So what's causing the floaters? This you can actually see by ultrasound. And here's an example of ocular trauma. We don't really know what's going on behind that eyelid, and it would be really hard to prop it open. And you might have some folks with trauma. You might have a bunch of them, and you might want to know if somebody has increased intracranial pressure, which we can actually tell by ultrasound. And then if you have someone with a really bad headache and you're thinking about IIH, you might want to use ultrasound to take a look at the optic nerve. So basically, if you're having trouble seeing, if you have eyeball trauma, if you can't get there with your ophthalmoscope, those are the things that we would want to look using the ultrasound. So there are a couple of studies looking at how good emergency physicians are with the ultrasound looking at eye pathology. And this one was specific to basically any type of posterior chamber abnormalities. And, there's not a huge number of studies. This was only really, 9 studies total that were included, about 1,200 eyes. So, and some of these studies were smaller, especially as you start looking at things like globe rupture and foreign bodies. So just keep that in mind. But basically, for retinal detachment, we're pretty good. The sensitivity was 9.94. Specificity was 0.94 as well. So pretty high. For vitreous hemorrhage, it's a little bit lower. and also for vitreous detachment. And I'm going to talk about gain, using gain a little bit, and I'm wondering, what level of gain they were using in those studies, because this may actually have affected their sensitivity and specificity. And then we have for lens location, also very good. Foreign body, very good. Globe rupture, which we want to use with great care when we're thinking about putting a probe on someone who we might have a globe rupture. So basically, ultrasound is pretty good to see various pathologies in the eye. So how do we do it? So our scanning technique, we're going to use a linear probe, a high-frequency linear transducer, and just like everything else, we're going to scan in the transverse and the sagittal planes, so orthogonal planes. It's really important in ultrasound of the eye that you anchor your arm or the base of your hand when you're doing this, so you're not putting a lot of pressure on the globe. So you want to anchor your arm. You can see in the picture on the right that the arm is actually anchored on the patient's shoulder. Some people actually use the base of their hand and anchor it on the patient's cheek. And some people even use a technique where they approach from the head of the bed and they use the patient's forehead or the bed to anchor their hand or their arm. I find that a little awkward, but I know some folks who do that, and it works really well for them. So the key point is to keep your hand anchored. So you're also going to need some gel, right? Because the eye is not a nice smooth surface. Just a little bit of gel won't go far enough. So you need a big blob of gel. And you can use ultrasound gel if it's a nice high-quality gel that's not going to run all over the face. Some people have also used Vaseline because it's nice and it's pretty gooey. It doesn't run down the face very much. And some people use a tegaderm over the eye. So they firmly place the tegaderm and then they put the gel on top of it. I personally have a hard time with that. I tend to get air under the tegaderm, and as you know, trying to see through air is somewhat difficult. So I do not use a tegaderm. I talk to the patients and tell them what I'm going to do, and then I put the gel right on the eye. And you might want to have them take out contact lenses if they are wearing them at the time you're taking a look. So when you're scanning, you're going to have the patient look to the left and the right. We'll go into the anatomy in a minute. And also you're going to have them look up and down in both of these views to help you see the entire vitreous. You can also watch the pupillary reaction. So if you put the transducer at the side of the eye, lateral to the eye, or even inferior to the eye, and again, you need a lot of gel, you can actually see the pupil. You can see the iris and the pupil really well, and you can see them, the pupil constrict. So basically, closed eye, thick gel cushion, anchor the arm, and then scan in sagittal and transverse with the patient looking up, down, left, and right. So machine settings, and these are really important in ocular ultrasound. A lot of times, we have a fixed machine setting and we don't think about it. And if we don't have that exact setting, we use something that's close to it. But with ocular ultrasound, you actually want to have an ocular setting. So your high-frequency transducer, you want to set your depth to about 4 centimeters, maybe less if you're really looking more at the anterior chamber and the pupil. You want to make sure you have focal zones that are looking at your area of interest. So if you're looking more at the anterior chamber, obviously you would want your focal zone closer to the near field. And here we have it kind of in the posterior field because we are looking at the posterior chambers. And then gain. Now this is going to be somewhat variable because you'll find that some things you can see really well with a low gain, but other findings of pathology in the eye, you actually need a higher gain. So basically your ocular setting, and we'll talk about why in a minute, you want to make sure that you're using focal zones where you want them and then changing the gain during the exam. So there's actually an article just last year or 2 years ago looking at the optimal image gain intensity for point-of-care ultrasound. And they basically found that a higher gain was appropriate. And remember that when you're increasing the gain, you're not increasing the power, you're not increasing the energy, you're just increasing how well you're listening. And also remember that when you increase the gain, you also increase the chance of artifact. So I would caution you, not to start with a really high gain, and to make sure that you maybe take a look at the other eye, make sure that's nice and clear, and then switch to the affected eye so that you know that you're not seeing artifact when you're setting your gain. So biosafety, and there's a couple places in ultrasound where biosafety is a real consideration, like with fetal ultrasound in the first trimester, and then ocular ultrasound is another place, because we are looking at really small parts, and the anterior chamber, which is filled with fluid, is really susceptible to getting potentially being damaged. So this was an article that looked at that, and there were a number of emergency medicine ultrasonographers who were looking at this. So yes, it's possible to cause harm with ultrasound. I will just say with a caveat that no harm has been demonstrated with the proper use of medical ultrasound. But it is possible, and we'll talk about how you can cause harm and how to prevent it. So remember that ultrasound is energy. It's a mechanical energy. It creates waves. And, we all think of happy waves on the ocean coming in, and we can play in them and we can surf in them. But then you also have the tsunami that comes in and wipes out entire cities. So, so waves can be a problem because they deliver force. And they can also cause something in fluid called cavitation, where they create these bubbles, and the bubbles can burst and cause all kinds of cavitation. So we have mechanical injury, but we also have thermal energy. I mean, think about it. Every time you're using some type of energy, say electricity, to power your computer, it has a fan on it, and if you set it on something and block the fan, the computer gets overly hot and tells you that it's probably going to shut down. So thermal energy is the other kind of damage that can be caused. And, I'm sure you've all had this happen to you, or you've seen it where your brain is using so much energy and your head starts to get really hot, and before you know it, there you are like Beaker with your head afire because of the energy use and the heat you've created. Okay, so why is the eye so sensitive to this? And it's really the anterior chamber. And it's first because it has a very small size compared to the rest of the eye and compared to other body structures that we're looking at. The second thing is that the cornea and the lens are avascular. So when you think about what happens when your body gets hot, like your skin gets hot, your vessels dilate, and you have the vessels dilate so they can get rid of some of that heat that's in the core. But the eye does not have the ability to do that because the cornea and the lens are avascular. And to top it off, the lens has a really high acoustic absorbent coefficient. So it is going to absorb a lot of energy and produce a lot of heat. So that's why the eye is susceptible to damage by ultrasound. So how do we present it? Well, of course, we always use as low as reasonably achievable. We want to use the ocular setting, and that's important because of our tissue and our mechanical indices and where they're set. Tissue indices needs to be less than 1, mechanical less than 0.23. Now, some sites say 0.30, but we're going to go with 0.23. So you can see if you're using the musculoskeletal setting on your machine, you think, well, I don't have an ocular, I'll just use musculoskeletal. And so, excuse me, our mechanical index, though, is 0.5, which is twice the safe level. So by having an ocular setting, and you can actually make one of these in most of the machines, you'll notice that the mechanical index is down to 0.2, which is a safe level. So just a word about training and credentialing. If you're an emergency medicine physician, the guidelines for training and credentialing are right in the ultrasound guidelines. And this is considered a core application. It is not considered an advanced application. It does not require a fellowship. It's actually considered a core application. And then for those of you outside of emergency medicine, AIUM has an official statement, the guidelines on performance of POCUS, and it goes into training and credentialing for all forms of POCUS, including ocular. So if you need more information on that, those are a couple sites to look at. All right, so moving on, let's talk about ocular anatomy. And no, that isn't a real eye before people start asking me. It's a nice prop eye, but it's such a good one that I had to include it. So your basic anatomy, we have the anterior chamber, which is filled with the aqueous humor. And then we have the bright line, which is the iris. And then just posterior to that, we have the lens. And so behind that, you have the posterior chamber where you have the vitreous humors, and then the optic nerve is behind that. You can see that as a hypoechoic area in the far field on this image. So just a couple things on the anterior chamber. So we have the pupil, which is where we're going to, enlarge it when it's dark and constrict when it's light, and that's important if you're assessing for pupillary responsiveness. And then the iris is obviously what controls the size of the pupil, and behind that is the ciliary body, and that it sort of acts like a trampoline. It's like this muscle that holds the lens into place, and sometimes the lens can actually jump off. So in our image, we have the iris on both sides of the pupil. And as you know, when you put light into the eye directly or consensually, you'll get constriction of the pupil. And if you can't see that, you can actually put light on the lid, both directly and consensually, and you will get the pupillary reaction. So there's our nice eye with our iris, and unfortunately my video, the eye is a little off to the side, but you can see the iris, and you can see with the application of light, it constricts, so the pupil becomes much smaller. However, this is much more easily seen if you come laterally or from the inferior position and scan the eye. So here we have our light being applied, and our pupil is nice and small. So if you ever need to assess pupillary constriction for a direct response or a consensual response, and you can't actually open the eye, you can do this with the lids closed. Okay, moving on to our posterior chamber. So this is full of good anatomical structures. So the sclera is that fibrous white tissue, and it attaches to the cornea, and then it goes, all the way back following the optic nerve. So you can pull the eyeball right out by its sclera. And then beneath the sclera, we have this choroid. And the choroid is actually a vascular structure. And you can see it's attached just kind of at the posterior aspect of the iris. And then it's attached back by the optic nerve. And it's highly vascular. And that can actually bleed into itself and expand, and you can get a choroidal detachment. And then, of course, under that, we have the retina, which is really our nerve ending that allows us to see. And then there's a spot in the retina called the macula. It's just lateral to the optic nerve, and it's really important for central vision. So when we talk about retinal detachments, we'll talk about MAC on or MAC off detachments, because if it's MAC off, it really disturbs the vision in the entire eye. And then, of course, the vitreous humor, which is kind of soft and squishy and jelly-like. If you've ever seen a nice globe rupture, you know that. The optic nerve, of course, coursing straight back to the brain. And then within the optic nerve in the center, you have the central retina artery and vein, very vascular structures that feed the eye. And, of course, if they get obstructed, it's somewhat problematic because you can't see. All right, so when you look at the eye with ultrasound, this is what you see. And it's like, okay, well, wait, where are all those layers? Well, you can't see them, so you have to imagine them. So we're thinking, okay, there's our nice white sclera, nice and thick. Inside of that, we have the choroid, which actually can become separated, the retina. And notice that the retina actually really attaches to the retinal, the nerve there, the optic nerve. And then, of course, we have the vitreous fluid in beside that, and then the vessels that go in. So you have to have a good imagination and imagine all of these layers. And of course, if one of them separates, you will be able to see that by ultrasound. So we talked about the indications for ocular ultrasound. We talked about the technique, the machine settings, safety, and how to optimize your image, and normal anatomy and normal ocular anatomy. Any questions? All right. Thank you very much.
All right. Thank you, Sandy, for that amazing lecture and for helping us get back to the basics here with ocular ultrasound and learning a little bit about how we can use the ultrasound on eyeballs to help our patients, in their clinical environments. We'll wrap things up here. Our next session will be coming up in a couple of weeks. One of our residents will be doing another case presentation. And then after that, Dr. Werner is going to come back for part 2 of ocular ultrasound basics. So you definitely won't want to miss that. If you missed anything, you want to watch this lecture or any other lecture again, hit up the YouTube channel, MetroHealth Emergency Ultrasound. We have all those videos posted there for you to see and watch and rewatch to your heart's content. And while you're there, if you have not yet subscribed, if you're one of the 85% of people who watch our channel but haven't hit that subscribe button, definitely hit that button, hit the notification bell so that you can be first to know whenever we drop new content just like this video. Until then, have a great week. Happy scanning. Go make a big impact in some patients' lives this week. Thanks for watching. See you later. Bye.